Good morning. Hello, everybody, and thank you for joining us today. I'm Maura Kelson, the Deputy Administrator for Programs at the Administration for Community Living. Today's conversation is a chance to hear from Aging and Disability Network organizations about the issues they're seeing as Medicaid renewals have restarted following the end of the COVID-19 public health emergency. In addition, we are joined by many of our CMS colleagues, as well as the National Association of Medicaid Directors. Given the critical role that all of us across HHS, our state partners, and advocates are playing during this redetermination process, we hope that our discussion will be productive, helping us all to shape future outreach and education, ensuring that people with disabilities and older adults who are eligible for Medicaid stay enrolled in the program. I will now turn it over to Allison Barkoff, who leads ACL, for some opening remarks.
Great. Thank you so much, Maura. And I'm just watching participants joining. I think we are finally slowing down. Just for accessibility, and Marcy, if you could pin me, thank you. Just for accessibility, wanted to make sure people know we have CART. You can get CART at the bottom of the screen. And of course, we have our ASL interpreter. As Maura said, hello, my name is Allison Barkoff, and I lead the Administration for Community Living, or ACL. And just a brief visual description, middle-aged white woman wearing a blue dress with curly brown hair and a blue background with the ACL logo. Thank you to all of you for joining us today. At ACL, our mission is to ensure that all people have the opportunity to live and fully participate in their communities, regardless of age, disability, or level of support they need. We fund a network of community-based organizations in every state and virtually every community. And these organizations provide a wide range of services and supports, like in-home supports, nutrition, legal assistance, and information and referral, including connecting people to Medicaid. Medicaid is critical to ACL's mission of community living. Not only does Medicaid provide important healthcare services, but many people with disabilities and older adults rely on Medicaid to provide the home and community-based services that make community living possible. Unfortunately, older adults and disabled people are at particularly high risk of losing Medicaid in the redetermination process. And this is particularly true for people who we aren't able to reach with intentional support or timely information. And that's why right now, one of ACL's top priorities is Medicaid redeterminations. I know everyone who is on this call today is working very hard to prevent people from losing Medicaid. ACL is working very closely with our colleagues in the Centers for Medicare Medicaid Services, or CMS. And I want to thank them for their partnership, commitment, and the intentional outreach they are doing to those in the Medicaid program, particularly working in partnership with us, with the aging and disability communities. I want to thank those of you joining ACL and CMS on this call for all you are already doing to make sure people don't lose coverage by ensuring they know about and complete paperwork, that they understand their rights, and they know about their health insurance options if they are no longer eligible for Medicaid. Even though we have collectively been working to make sure everyone who will need to renew their Medicaid coverage has the information they need, we know issues exist, which is why we are all here today, to learn more from our external partners about what all of you are seeing on the ground. We want to ensure that the people served by our networks not only know about the renewal process, but are able to access the help they need to navigate the renewal process. Making sure communications around renewals are accessible and understandable is a huge part of this effort and critical for states not only in fulfilling their obligations under Medicaid, but also to comply with obligations under civil rights laws like the Americans with Disabilities Act, Section 504 of the Rehabilitation Act, and Section 1557 of the Affordable Care Act. The reports we hear from you tell us what is working in the community and where there are gaps. And this information is so critical to helping us in the federal government and state partners in shaping future outreach and education. For example, we have found that people who lose Medicaid coverage often aren't told and do not know that they have a right to appeal the denial. And as a result, we have put together several plain language blogs and have done individual outreach to our grantees to share this information. Our efforts cannot let up. We have to continue our collective work to make sure people stay covered, and we must continue to have discussions like the one we're having today. So I want to just end my opening remarks by once again saying thank you for all you are doing and for your partnership. Speaking of partners, I'm now going to turn it over to Kate McAvoy, who is the Executive Director of the National Association of Medicaid Directors, or NAMD. Thank you, Kate, for your leadership during this intense time and for your ongoing focus on the redetermination process. Kate?
Administrator, thank you so much for those extraordinary context-setting remarks and for the opportunity to link arms with you, our federal partners at ACL and also CMS, as well as numerous other federal agencies that have shared interests in these matters, and also all of the folks on this call who are doing such yeoman-like work. I will just start with thanks for all you did during the intense period of the pandemic to ensure access and continuity of services, particularly for older adults and people with disabilities served by Medicaid. Obviously, there were tremendous demands on all of us to pivot rapidly to change the mode and means of connecting with people through such interventions as telehealth and the Appendix K authorities. Other features, however, really illuminated longstanding challenges with the eligibility process that we had the opportunity to smooth during the pandemic. In fact, the continuous coverage requirement that preserved eligibility for folks over the course of the public health emergency, I think had an extraordinary effect for especially those folks we're most concerned with in this discussion in terms of minimizing the stress and burden of the renewal processes. It also gives us the opportunity in this watershed year where we are emerging from the pandemic with the attention the federal government is bringing to improving, smoothing the access to the Medicaid program and also preserving continuity of coverage. And the federal government is emphasizing that through rulemaking, but also the processes of compliance of the unwinding process. It's an important call to action to those entities I represent, the 56 Medicaid programs in states and territories, and I'm very honored to be here to listen on their behalf. States and territories are deeply interested in the observations and lived experience of folks on this call and otherwise who are very close to people in their day-to-day experience with the renewal process. I'm conscious this is a Herculean effort. We have, as of April, an apex enrollment in Medicaid of over 87 million people. That's close to 1 in 4 of our fellow Americans. As you understand all too well, this is a significant undertaking for states from a system standpoint, but we always want to be motivated by a person-centered approach at each and every juncture point, from the outreach and engagement, as the administrator spoke about, the accessibility of the means of communication and the translation of messages into something that will be compelling to people who face complex life circumstances. Also, the process of enabling people to be assisted in understanding paperwork, in effective communications where they need more help with programs like call center staff. I want to acknowledge the volume of the activity has created unprecedented demand for that type of support. And in fact, states are very challenged right now to respond in the level of intensity that is being created. I'm also want to squarely call out the phenomenon that although we have an unprecedented level and intensity and means of outreach to people across the country, we still have many people who are not responding to those notices around renewal. For this reason, state Medicaid programs are focusing on each and every protective mechanism to retain coverage and, where necessary, to restore it, including an intensive focus with CMCS on the ex parte or passive renewal process, which we all see as an amazing opportunity, especially for folks who have stable incomes and relatively unchanged life circumstances, but also the process of reconsideration periods and supports for people should, in the worst case scenario, they fall off coverage, wanting to examine how best to do that with as minimal effort and burden on them as feasible. I am here to listen today and to convey directly back to our membership what you see and feel about this process. And we are all deeply committed in this watershed year to permanent improvements in the eligibility processes that we know will be meaningful for people. So thank you so much, and I'll turn back to Maura.
Thank you so much, Kate. And we really very much appreciate you joining the call today and sticking around and listening to the rest of the presenters. So with that, I will turn it over to our colleagues at CMS. I believe Perry Briskin, Senior Advisor in the Center for Medicare and CHIP Services, will be chatting about Medicaid's work in this area. Thank you.
Thank you, Maura, and thank you everyone for having this call and joining us here today. And thank you so much to Allison and Kate for those really remarkable opening comments. So I will just reiterate from the Center from Medicare Medicaid Services, and specifically the Center for Medicaid and CHIP Services, our wholehearted commitment to making sure that people who are eligible stay covered. We have been working for, I would say, upwards of 2 years with states to prepare for this time, and we continue to work just about around the clock to make sure that states have what they need and that people have the resources they need to keep their coverage. We are always looking to hear from you all, and I think I'll see many familiar faces in hearing from you what is working and what is not, where you are seeing issues, and where we as CMS, in partnership with NAMD and states, and also with Allison and her team at ACL, what we can do to address those issues. It is a moment, and not dissimilar to the pandemic overall, that has shown a light on what is not working with our systems. And so we hope that we come out of this for the better, but right now we know we are all in it and it is really hard. But I think this is all also showing where we need to work to make greater investments in our systems and fix longstanding issues with the Medicaid program that drive inequities, especially for certain populations like those with disabilities and older adults. I will say that, Medicaid coverage and keeping Medicaid coverage, we recognize, is essential for people who are receiving home and community-based services, and there should be no gaps in coverage. And so that's what we are working very hard to do. So thank you for being here. As Kate said, we are here to listen and to be able to answer questions, and we look forward to the conversation. Thank you so much for having us. And with that, I will turn it back over to Maura.
Thank you so much, Perry. We are now going to really shift to the meat of today's discussion from reports from the field. So we're first going to hear from Carrie Glover from NCOA, the National Council on Aging. She is their Associate Director of Research and Evaluation, and she's going to present some survey results. I will turn it over to you, Carrie. Thank you.
Thanks, Mara, and thanks everyone for having me as part of this conversation today on behalf of the National Council on Aging. I'm Carrie Glova, the Associate Director for Research and Evaluation. I'm here to share with you all about the survey initiative that we are conducting on behalf of the Administration on Community Living. And this is a 4-cycle survey, the first of which we had just completed in July of 2023. So the data is actually fresh off the press. We will be repeating the cycle of these surveys about every 2 months or 2.5 months to really understand and gauge the impact that the Medicaid unwinding of the continuous enrollment provision is impacting beneficiaries, as well as the enrollment entities that are tasked with supporting them. So just a little bit about the survey itself. It's in total about 20 questions that is distributed throughout a listserv made up of NCOA and ACL grantees. And the survey has a series of different questions, but really focusing on trying to understand the demand that is arising on these enrollment agencies as they are providing assistance related to renewals. We collect some information about the characteristics of the beneficiaries that they are working with, as well as the characteristics of the different assistant types. So different ways communications are being shared and kind of leading people to reach out to seek assistance, the different resources that folks have access to in supporting these renewals. And also a number of improvements that folks in the field feel like are really important in their journey to assist these folks. We also asked some questions of the enrollment entities themselves in trying to gauge what their experience at different points of at different cycles about their capacity and their ability to assist, and their attitudes and opinions about their state processes and kind of what their experience is, and essentially as the renewals continues. So for today's conversation, we really highlighted 4 main data points that we felt would help set the stage, and again, providing information really at a national level with a national focus. This first cycle of survey results, we were able to have representation from 36 states and about just under 230 survey responses. So as we continue, we hope to maintain that kind of level of representation, if not bolster it even further. So the first data point that I'll share with you today, early in the survey, we do ask the type of entity that a respondent belongs to, whether that's a SHIP office, senior Medicare patrol, a benefit enrollment center, or perhaps another community-based organization. And in this first cycle, we heard that 91% of the respondents represent SHIP offices. So we assume or might infer that this will kind of continue to really be the bulk of the respondents, but we'll be interested to see how that varies kind of as the cycles continue. But for now, in that first cycle, 91% of respondents is represented SHIP offices. We then ask respondents to indicate the volume of the calls or the inquiries that they're receiving related to unwinding assistance, related to the unwinding assistance. So the option choices came in ranges of 10, from kind of 1 to 10 calls per week, 11 to 20, 21 to 30, and then over 30 calls per week was the kind of high range of those assistant related calls. In this first cycle, 55% of respondents said that they're receiving up to 10 calls a week. So that was kind of the bulk of folks responding, but we did see folks, about 21% who said that they were receiving 11 to 20 calls per week, 9% of folks who said they were receiving 21 to 30 calls or inquiries per week, and then a 10% of the respondents that said that they were receiving 31 or more inquiries per week. So there is a wide range of the volume of calls that folks are receiving so far. And the kind of average experience in this first cycle is in that 1 to 10 range of calls per week, but we're seeing up to even upwards of 20 to 30 calls in some smaller representation. I mentioned earlier that some of our questions we do ask about attitudes and opinions of assistance or enrollment agencies or folks themselves in terms of what their experience in the field is like so far. So one of the questions that we asked is for respondents to share how they felt in regards to their capacity and their preparation in order to be able to assist these beneficiaries. So that was kind of your typical Likert scale question. that asked them to agree with that statement or rate their response to that question, to that statement from a range of, agree or disagree. And the majority of the respondents to that question, 76%, agreed with the statement that they said, yes, they feel equipped to assist in beneficiaries in the renewal process. So that's an overwhelming majority. We then, though, pair that with the second statement that is asking those same respondents to rate the effectiveness of their state's outreach regarding the redeterminations process. And while 76% did say that they individually felt, prepared or equipped to provide that assistance, 48% of those respondents said that they were neutral to the statement regarding their state's effectiveness related to the outreach around determinations. So 48% said that they were neutral, and in fact, just 40% of respondents then said their state outreach process was effective or highly effective. So most folks landed in that very neutral range. Again, it'll be interesting to see how, as the renewals continue, how those attitudes and opinions might change, both on their individual kind of experience of being prepared, but then their experience as being part of a larger system and the effectiveness of that kind of larger system. The last data point then I'd like to highlight is related to improvements. So respondents were asked, how could your state's redetermination process be improved? And in this type of question where we kind of list a number of options, all of the answer options were indicated as helpful improvements. So some of these things include increasing phone answering capabilities at Medicaid, making the notices more understandable for beneficiaries, reducing the recertification documents required, as well as providing better access to translation services and auxiliary aids. So again, folks indicated that all of these were important improvements, but the top category was the first. 81% of respondents said that increasing phone answering capabilities at Medicaid was the #1 most needed improvement as of this first cycle. The last thing I just want to note is that we did this, the survey is primarily quantitative so that we could really focus on monitoring and comparing, answers over time, but we did include some opportunities for folks to give some narratives and some more qualitative data to contextualize the numbers kind of beyond that. So I will turn it to the next part of the agenda. I want to say thank you on behalf of NCOA, and we're excited to be able to compile this analyses and continue being part of the conversation. Thanks, Maura.
Thank you so much, Carrie, and thanks to NCOA for that really important work. I'm now going to turn it over to hear a little bit about specific challenges that the dual eligible population are having as part of the redetermination process. Of course, those are individuals who are dually enrolled in both Medicare and Medicaid. And for that, I will turn it over to Galila Selassie, who is a senior attorney with Justice and Aging. Thank you.
Great. Thank you, Mara, and thank you, ACL and CMS and everyone for allowing us to be on this call. As Mara said, I'm Galila Selassie. I'm a senior attorney at Justice and Aging, and we've been particularly focused on the dually eligible population as we continue with unwinding. As is the case for many folks who are engaging in unwinding, a lot of the issues we're seeing and the challenges we're seeing are problems that have existed even before the pandemic, but the nature of unwinding has sort of exacerbated these problems and caused it to occur all at once, and has been really magnifying some of the challenges that states have in their existing systems. And so there's a couple sort of big bucket areas that I'm going to address related to duals. One is about the lack of information and confusion around the Medicare special enrollment period for individuals who lose their Medicaid coverage. And then the other are issues related to data exchanges between Medicaid, the state Medicaid agency, and the Social Security Administration for getting individuals all different kinds of Medicaid benefits. Regarding the Medicare SEP, we've been hearing about Medicare eligible individuals who might receive Medicaid termination notices. And many instances, these are people who've already been enrolled in Medicare or recently became eligible for Medicare. And they're receiving notices saying, your Medicaid is terminated, but you qualify for a qualified health plan through the marketplace. which isn't the case. People are not eligible for tax credits if they are, in fact, Medicare eligible. And so that's a big problem as well. There's a lot of misinformation that's happening. We've also heard of some Social Security offices unaware of that Medicare special enrollment period and having to, telling individuals that if they miss their initial enrollment period for signing up for Medicare, they have to wait until their general enrollment period in July, which means that not only is there going to be a gap in coverage, but it also means that they may face a late enrollment penalty for the rest of the time that they're on Medicare. And again, that's also really detrimental and really problematic as well. So a huge thing is to make sure that folks are aware of this Medicare SEP, both partners, SHIP counselors, state advocates, state agencies, really making sure that there's recognition that the marketplace is not the only SEP, and making sure that those notices are tailored for these specific populations. And then, as I mentioned, the other big issue has been related to sort of the data exchange that exists between Medicaid and the Social Security Administration. So once such exchange of data occurs for people who are enrolling in a Medicare savings program or an MSP, generally individuals, as folks may know, people are told, sort of inundated with Medicare notices months before they begin their coverage. And the reason for that is that once they're found eligible for Medicare by a particular date, they should be able to enroll in this Medicare savings program through the state if they are eligible, so that it is effective that first day of coverage that their Medicare becomes active. Unfortunately, that's not happening in a lot of states. Again, this is a problem that existed pre-pandemic, but has been really magnified as states paused their redeterminations. And so instead of states seeing that someone is beginning their Medicare eligibility, say on October 1st, and so going ahead and enrolling them into the MSP with an October 1st start date, folks are not able to enroll in their MSP until after that October 1st Medicare effective date, which means that they've already had their premiums taken out of their Social Security, or typically it's taken out of their Social Security. This can be really problematic because folks who are enrolled in Medicare savings programs are very low income, have limited assets, and in some instances of extremely low income individuals who are part of the Qualified Medicare Beneficiary Program, or QIMBY, they are actually not eligible to receive retroactive coverage. So this delay in coverage is particularly detrimental. Relatedly, there are challenges between individuals. So that's one challenge, is making sure that the state is able to verify someone's enrollment in Social Security and making sure that their Medicaid is starting by that Medicare effective date. Relatedly, individuals who are currently enrolled in Medicare and in Medicare savings programs are being terminated despite being eligible. In some instances, we've seen people who have been enrolled for 20 years, 30 years receiving a termination notice. And again, this is due to the fact that the state is unable to verify their Medicare enrollment, despite this being they're having this continuous coverage in Medicare. And so again, just making sure that the state Medicaid system is able to communicate and able to access some of the Social Security data. And then switching gears a little bit from the MSPs, there are a lot of people who are on SSI Medicaid who are being asked to complete these completely new renewal packets to continue their SSI Medicaid. So a significant number of states, we often refer to them as Section 1634 states, have agreed to use the Social Security Administration's approval of SSI benefits as automatic approval for Medicaid. And so in the bulk of those 34 odd states, what should be happening is that once the state sees that the Medicaid, that they're receiving SSI from Social Security, they should just automatically get their SSI Medicaid. And at renewal time, their review should be either ex parte, meaning they're just getting that data from Social Security, possibly sending a verification notice saying, just confirming this is your income and assets. But they really should not be receiving brand new pages and pages of packets of information, asking them to go out of their way and affirmatively show this is their income, this is their assets, because this is a population that is disabled, that is aging, and already has very, very limited income and very limited opportunities to go about doing these things. And it's already been done by Social Security, and the state agreed to do that. So that is a huge challenge as well. Even if the state can't verify for whatever reason their SSI enrollment, part of this ex parte renewal also means checking if they're eligible for other Medicaid categories. So if they're not eligible for SSI Medicaid, again, this is usually a population that's has a disability or is over 65 or over. So they're likely going to qualify for a Medicaid for Disabilities program or Medicaid for Aging Adults program, which are two required categories for every state for Medicaid coverage. And so again, there really shouldn't be this brand new packet of information saying, prove to us that you're still eligible. The state has the data to be able to do that themselves. And then again, for this population, SSI Medicaid population, they could also be receiving a Medicare savings program. So these individuals who are below the poverty level are once again having their, in many instances below the poverty level, are having hundreds of dollars potentially taken out of their checks every month. And so those are some of the big things we've been seeing. It's still very early days, and we've really been focusing on a couple of states that have seemed to prioritize older adults and duals in their unwinding process. But I did want to flag that for folks. This is a population that likely is not going to have a lot of life changes. Usually older adults and people with disabilities are on fixed incomes, very often are not really returning to work at a large scale. And so seeing a lot of terminations or fluctuations in coverage for this group should be a little bit of a red flag to see what is going on with underlying systems. And so that is it for me for talking about duals. I can pass it over to Mara, or I can sort of dive right into this next area that related to sort of the problems that occurs between gaps in coverage.
Yes, that would be great. And I believe you're going to be joined by Elizabeth Edwards from NHELP. Thank you. I'll just please keep going.
Okay, great. Thank you. I'm sorry everyone has to hear me talk for so long. But just to begin, and Elizabeth will jump in many instances, you know, we want to make sure that folks are aware that this gap in coverage, or if there's a gap in services, that it can't just be remedied and everything will be okay. Of course, even if if someone is improperly terminated and they get reinstated or they reapply, maybe they get retroactive coverage, or maybe they're able to just lose those couple months of coverage and then restart. But in some instances, that's not a sufficient remedy, and it can be really detrimental long-term. For one, I mentioned that for some people on the Quimby Medicare Savings Program, there's no retroactive coverage. So when they lose their Medicaid termination, when they lose their MSP, they're losing hundreds of dollars from their Social Security checks that they're not able to get back retroactively. And Quimbys are also the only Medicare savings population that get Medicaid to cover their Part A and Part B premiums. And Part A premiums are incredibly expensive. So this is a population that if their Part A and Part B is potentially covered by Medicaid, they could be on the hook for up to $500, $600, which is greater than 50% of the standard SSI rate, federal SSI rate. And they're not going to get that back. So that's one challenge there. Another big one is for the is for people who are enrolled in long-term services and supports through Medicaid. When they lose their coverage, they lose access to these providers. And particularly in the home and community-based services space, which is an optional benefit, funding is much more restrictive, and the provider network is a bit more complicated because it's done through Medicaid waivers. When those folks lose their Medicaid coverage, that typically means that these providers are no longer seeing them. And because there's such a provider shortage and long wait lists, and a lot of people who are relying on these services to stay in their community or in their homes, when those services are cut off, then their provider sort of moves on to the next client on the list who needs those services, who needs their services, because they can't or aren't willing to provide that overhead to continue the services for their existing client that lost Medicaid. And because these are often very small providers in very niche areas, again, because of the nature of HCBS waivers. So not only does this person go a few weeks or a couple months without services, but it's very likely that when Medicaid is reinstated, and even then during that couple months without coverage, there could be falls, there could be illnesses, missed appointments, all these really detrimental things. But on top of that, they might not even be able to get back on with their providers in the future. Or they'd have to have a very long wait list or sort of start all over again and getting back to their necessary services. So there's a couple really important challenges that is really putting older adults and people with disabilities in really extreme jeopardy if their Medicaid is not being assessed properly. With that, I will pass it to Elizabeth or any others who have a little bit more to say on that.
Yeah, I think that covered a lot of it, but I wanted to hit on a few things, especially around the gap in services. So a lot of times we think about retroactive coverage. Oh, it'll just cover things. And as Jalila said, it really isn't that simple, because if a person loses coverage who uses HCBS services, the provider often won't continue services on a hope that the person will be reinstated. And that, as sort of was mentioned before, it can lead to somebody falling and being hospitalized, and the hospitalization can lead to long-term institutionalization. And if a person loses their housing, it's very difficult in a lot of areas to get housing back. And so just a short gap in coverage that many people may not think that much about is intensely life-changing for people who use HCBS. Especially as Jalila sort of talked about before, that there's a real lack of providers. And so once you lose your provider, even if they, are saying, oh, well, you won't have me for a couple of days, they have other jobs they can go to. It's very hard to find a provider. I also wanted to dig a little deeper on the missing the specialist appointment. So if a person has to miss an appointment because they no longer have coverage or have a gap in coverage, many people with disabilities have specialists with very long wait times for appointments. And if you miss that appointment, you can't just go in the next week when your Medicaid coverage is back. Oftentimes there are months-long waiting times for specialists, and that is very harmful to sort of ongoing health, including maintenance of certain health conditions, as well as identification of treatment options for health conditions for people with disabilities. So it's a gap in service isn't just as simple as paying for services that were provided in the gap, since oftentimes those weren't provided at all. And we really must protect against that first domino falling due to loss of eligibility causing a gap in services. It's not only important for Medicaid coverage, but it's critically important for a person's civil rights, like Allison mentioned at the very beginning of the call, the right to live in a community under the ADA in 1557 and Section 504. It's not just about living in the community, but being a part of it and being stable in that community. So I really encourage everybody to think about protecting against any type of gaps in coverage, because it's not as simple as just paying for something that was provided.
Thank you, Elizabeth and Galila. Really important information for everybody. I'm going to do a little bit of a pivot right now. We're going to talk a little bit more about communications and outreach to the disability community and enrollees with disabilities during this next block. And I am going to turn it over to Elizabeth Prio from the National Disability Rights Network and hear from her. And then after that, we'll just have one more smaller panel, and then we'll open it up for some discussion. Thank you.
Okay, I'll be brief because Allison mentioned some of this in the beginning, that ACL has made information available for individuals in plain language. And I know that a webinar was held on how to do outreach to people with disabilities. I think it's really important that this information gets pushed out, because I should have told everyone I'm from, I work at the National Disability Rights Network. I'm a middle-aged woman with blonde hair and glasses. And the National Disability Rights Network has members in every state and territory. And we hear from them about issues they're seeing with unwinding. And one of the issues is not knowing that they can obtain materials in plain language. So it's good to know that ACL is having these webinars and has these materials available. And I and others are working with ACL to help with this, but we are still hearing that individuals are looking at their materials and have a very hard time finding the tagline somewhere that say that information is available in alternative formats, and might not think that alternative formats could include coming in person or obtaining information in plain language, that sort of thing. So so that is an area of big need. And then we are also hearing of numbers where people are referred to go to for more information, having very short open hours. So they might be closed around lunchtime and finish at 5 o'clock. And for many people with disabilities who rely on personal care assistance to help with communication over the phone, these shorter hours have been a big problem. And another thing that we've heard is from folks who say that the contact numbers they've been provided to call for more information, they call and there's no option right up front to make it easy to request information in Spanish. And apparently this is a big issue in some states because the line and the amount of time it takes to just get through to a person to then ask for information in Spanish has been an issue. So these are some of the issues that we're seeing, even with the big attempts that ACL and CMS are doing to ensure that their information is available. And one of the things that I was thinking about as far as Spanish language access is that with states put efforts to identify information ex parte, it probably one of the information available is that the person's first language is a different language. So they might be able to automatically send those individuals information in both English and Spanish, and systems like that. So Elizabeth Edwards might have more to add on this.
I think that was good. We just move on. I think we're running late, so you
Okay.
covered everything well.
Thank you. Thank you, Elizabeth, for mentioning the ACL resources. We're working to get those into the chat for folks, but in the meantime, you can find those resources if you go to the ACL webpage. It's acl.gov, and you can see there we have a header. Right in our header, we have a link to all of our redetermination resources at the top of our first webpage at the homepage. So I encourage folks to use those, and it links also to all of the resources that our CMS colleagues have as well. So for our last discussion piece, I'm going to turn it over to, oh, I'm sorry, I think we actually have two more pieces. I'm going to turn it over to Terry Anstey from Disability Rights Texas, and also Elizabeth Edwards, I believe, is going to be chiming in here again, talking a little bit about some of the confusion that folks are having as they're receiving the information about redeterminations. And then we'll just turn it back over to a larger group, a little bit about what happens after people are receiving denials. So thank you very much, Terry. I'm going to turn it over to you.
Thank you. Thank you for having me, Maura. Again, my name is Terry Anstey. I'm with Disability Rights Texas. I'm the supervising attorney for the Community Integration and Healthcare team. I'm a middle-aged male with brown and gray hair with a full gray beard with a black mustache and black glasses. Just talking a little bit about the type of renewal notices that individuals were receiving when the unwinding started in May. They're supposed to be yellow envelopes with red lettering. Unfortunately, the data that we've received back from Texas Health and Human Services Commission regarding the unwinding from May to July shows about 53% procedural denials. And so we have concerns that that individuals may not have received renewal notices in the mail. We're also concerned with the 2.5% ex parte renewals in Texas. It's a very low ex parte number. Elizabeth just grimaced. That is not surprising. And so we're concerned that the information that Texas Health and Human Services Commission had as related to people's addresses was incorrect, or perhaps they didn't have access to managed care organization information regarding people's addresses that they could have used for ex parte renewals. I'd like to also talk about, I know that Elizabeth's going to talk a little bit about denial notices, but I do want to talk about some of what we've seen so far related to the denial notices. I don't know, Texas may use an older program, but what most people get is 9 to 10 page denial notices that contain boxes that say, okay, this person can get Medicaid or this person can't get Medicaid for various reasons. Many times the reasons go through different, renewal options or Medicaid programs. If that don't seem to fit the person. They have string cites to like state, federal law and handbooks that aren't very specific. We're also seeing some, I've had a couple instances of really absurd notices. An individual receives a notice that says, you can't get Medicaid because you already get Medicaid. And it typically where we're seeing this is individuals who move to Texas from another state during the public health emergency. And the two instances I've seen, they receive SSI. Then they're told to do a whole new Medicaid application, and their Medicaid is not being activated in a timely manner or at all. I have two cases that I'm looking at right now with that. And the going back to the renewal notices, individuals are being told if they have questions that they can call the call center, which in Texas is 211. We're hearing from people that there are long wait times when they get on the phone. Some big concerns are people are saying that they will call in a few times in the same day, and they're being told different information depending on who they talk to. And they're also receiving different information depending on who they talk to when they go in person to a Texas Health and Human Services Commission office in person. I went to a conference last week on poverty law the state bar hosted, and I heard from a lot of our LSC funded legal aids that they're hearing that people are being discouraged from appealing denial notices, and that they're being told to complete a whole new Medicaid applications because allegedly that's going to be faster. But I think that's causing people a lot of confusion, and potentially there's going to be just due process issues if they're being discouraged from appealing and being able to receive continued services if they appeal within, for example, 13 days in Texas. So that's what we're hearing in Texas right now related to individuals' confusion.
Thanks, Terry. And I'm Elizabeth Edwards. I forgot to introduce myself before, but I work with the National Health Law Program as a senior attorney, and I'm a white woman with brown hair pulled back in a ponytail and glasses, in a sleeveless black shirt because it's hot in most of the South right now. So just more on the confusion, I think Terry covered notices really well, but just as a reminder to everybody, notices must explain what action the Medicaid agency is taking and why, including the basis of the decision. And a lot of the notices that we've seen, including some of the ones Terry and those at Disability Rights Texas have sent us, really don't help a person understand what action the state is taking and what they may need to do to keep their services. So for example, Terry gave a good example, but then we've also seen another one where it says you are not eligible for Medicaid under the expansion group because you're eligible under the expansion group, so you'll be receiving Medicaid under the expansion group. What is a person supposed to do with that? Much less a person with a disability who may have cognitive issues or may have learning disabilities or may just in general have trouble understanding complex notices to start with, it's really hard to know what you're supposed to do. We've also seen notices that require a response, and including returning information by a date that's a month before the date on the actual letter. Like, and when, as Terry mentioned, when you call the call center to get help, oftentimes you get information that is not consistent, that is inaccurate, and very rarely we're hearing a lot of problems, with people with disabilities getting accommodations at call centers. So call centers may have goals where they only spend so much time per caller to try to make sure that they answer calls in a certain period of time, and they don't provide accommodations needed for people with disabilities, including longer explanations or reading the notice to somebody, or sort of helping them understand what they need to do from the notice. The other big issue we've seen with notices is when it's a household of multiple people. It is often quite hard to understand what is happening to each individual's Medicaid eligibility and what they need to do or not do in order to make sure they continue their coverage. I think this is leading oftentimes to a lot of the procedural denials where people don't respond because they quite simply can't figure out how to do it. And when they reach out for help, either at call centers or at local offices, they don't get correct information, or they don't get any information at all. We are starting to hear that local offices are simply turning people away and saying they don't have time to help them, and they don't have time to accept their paperwork, and they just tell people to go home and submit it online, and many people cannot do that. That also violates the requirement that people be able to submit Medicaid information in person, online, over the phone, through other mechanisms. The other thing I really wanted to highlight is that we're quite worried about whether or not people with disabilities are having access to the program as is required by the Americans with Disabilities Act. When a program starts to sort of be under stress or otherwise encounter difficulties, one of the first things that often falls to the wayside are the programs and services and changes that are intended to help people with disabilities access the program. And it's just really important that states are paying attention to, and CMS and ACL and others are helping enforce, that programs have to ensure they continue to provide people with disabilities access to the program, and in this case, coverage, even when they're under stress. I think that's, I think we're turning it over to Sally now. Is that correct?
Correct. I think we're going to hear from Sally and whoever else would like to chat a little bit about denials. And then we'll open it up to the panelists to see if there's any questions or clarifications that they'd like to offer. So thank you.
Thank you, Maura. I'm Sally Pung, and I have the honor to serve as Michigan's State Long-Term Care Ombudsman. So as way of introduction today, I am a middle-aged white female with dark hair with a little bit of gray in there, glasses, and I'm wearing a pink jacket today. So thank you for having me be part of this panel. Today, I wanted to talk about something very specific that we are dealing with here in Michigan, and it has to do with functional eligibility for residents that require a nursing home level of care to maintain their Medicaid benefits. So in Michigan, those are individuals who are in our PACE programs, our home and community-based waiver program, as well as people in nursing homes. And my program serves those who live in nursing homes. So I wanted to share a bit about the impact that those denials can have on those individuals and what we've done to try to address those here in Michigan. So as everyone knows, the pandemic ended on May 12th, and we had a flood of individual residents in nursing homes who were suddenly determined to not be functionally eligible for Medicaid. Although our state put in an unwinding process that would stagger those reassessments, there was some confusion, I think, on the provider's end. We also have heard that some corporate offices encouraged reassessments for residents that were untimely, but it left hundreds of residents with notices that they had to leave the nursing home because they were ineligible. They have rights to an appeal, and after that appeal, if they're not functionally eligible, they still have the right for an involuntary discharge. So a lot of miscommunication, but the impact for many of those residents, is devastating. Like my colleagues talked about earlier about the loss of services or the gap in services. These are individuals, some who had been in the nursing home many years prior to the pandemic. So these are long-term residents who miraculously improved functionally during the pandemic. We just found that not to be true. These were residents that were being targeted because they weren't no longer welcome to be in those homes. And I think this was an opportunity for homes to try to discharge certain populations of long-term care residents. And then there was another portion of those residents receiving notices who were individuals who maybe came down with COVID and were transferred to the nursing home during the pandemic and were allowed to stay because we had a waiver on doing redeterminations. And those are individuals then that lost the connection to their community. Some individuals without income, and it's very hard to transition individuals without income or that have service needs and don't have eligibility for Medicaid back into the community. And just quickly, I know we're short on time today. I wanted to share with you the impact that it does have. These residents are devastated. There are a few that say, that's okay, I'm ready to leave. And we're glad to refer them to other services and agencies and help them transition into the community. But for some of those residents, particularly the older residents who are in their 70s and 80s, who've been living there upward, some as much as 10 years, to receive that kind of notice is just devastating. You feel unwanted. You already are dependent on care and services, and then you're told you can't receive them. And oftentimes in Michigan, we have those residents under a guardian, and the guardian isn't always as responsive to help those residents out. So I think on the other story I want to share with that is that we ran into roommates of those residents who received those notices, and the roommates were devastated, thinking it can happen to me next, because that roommate couldn't identify how their roommate who got the notice was any different than them. They had the same level of needs. Very devastating. Residents in tears, distraught and very stressed over this. So I wanted to say that I was grateful here in Michigan that our state Medicaid agency dedicated a number of staff to help address those concerns. They made themselves available when we submitted concerns to them and identified homes and identified residents with resident consent. They helped educate the providers in one-on-one phone calls. They worked through the appeal process to identify where residents were being inappropriately assessed and communicated that to our administrative law judges. So I think the response was appropriate. What I want to share today is that for those states that are starting to look at Medicaid eligibility, to make sure that you're including that functional side. And I think the best tip that I can offer was that early on, before the end of the PHE was announced, our state Medicaid agency agreed to include the ombudsman program information in those notices for nursing home residents. And without that, we probably would not have been notified about so many residents that were being inappropriately assessed and told they were no longer functionally eligible. Thank you.
Thank you so much. I'm going to start opening this up for a little bit more discussion now. I believe I'm going to turn over to our CMS colleagues who can perhaps provide a little bit more information on the SSA issue that Galila raised earlier. So, and then please, after this, if you want to raise your hands, and I will call on folks who have questions or comments. Thank you. And I'll turn over to Alice.
Thanks so much, Maura. This is Alice Weiss. I'm the Deputy Director of our Children and Adult Health Programs Group here at CMCS, the Center for Medicaid and CHIP Services at CMS. I did want to highlight one resource that's available. I know it sounded like when I heard Galila raise the issue about individuals being inappropriately being asked to reestablish their eligibility for SSI benefits, that in the 1634 states that was a problem. It sounded like she understood that wasn't appropriate, but I did want to flag that CMS did put out some guidance to states affirming that they can in fact rely on the SSA determination and should not be reassessing eligibility at renewal for those beneficiaries who are eligible for SSI benefits in a 1634 state. That information is on question 18 of a frequently asked questions document that I've shared the link with the ACL folks and will be posted in the resources. All of our resources on unwinding are also on medicaid.gov/unwinding, which is a great resource space for folks who want more information on our guidance and information, but there's a lot of information there. So I just wanted to point that out for folks. The second thing that I did want to offer, and I should have started by just appreciating all of the great information that's been shared on this call. This has really been beneficial to get to hear a little bit more detail about what's happening on the ground. And like Perry and others who've already expressed appreciation, just wanted to share appreciation for all the hard work that's happening on the ground to support beneficiaries during this time. We all share the goal of ensuring that individuals can retain coverage. I did want to say that in general, our work is best done in situations where we have pretty specific information on the violations that are being identified at the ground, so we can work with states to try to correct them. So if the folks who had shared concerns about, notices or a failure to comply with certain requirements, have specific information that they can share on a state notice or the state they're working with that they have concerns about. We are talking with all of these states all the time and collaborating with Kate and others at NAMD to ensure that we're providing states with all the guidance they need to be able to be compliant to the greatest extent that's feasible. And so we really appreciate the information when you can share it, and you can share it with me directly or with our unwinding mailbox, which I'll share also in the chat in case folks want that information. So thanks so much for the opportunity to join. I also have my colleagues on who are subject matter experts, and to the extent there's a discussion or a need for additional information, I know they're happy to jump in and share additional information. So thank you.
Thank you so much, Alice. At this point, does anybody else have any comments or want to ask any of our CMS or ACL colleagues any questions? Okay. Well, if that is